Hi there, Rachel. How are you doing today?
I'm excellent. How are you?
I'm doing very well. So, if you could just for us, real quick, introduce yourself, give us your name, your title, a short bio about yourself, your credentials, and then when that's all done, could you please state the title of the article you'll be talking about today?
I'd be happy to. So, my name is Rachael Jividen. I'm an acute care clinical nurse specialist and the Cleveland Clinic Health System ECMO coordinator at Cleveland Clinic main campus in Cleveland, Ohio. And my specialty includes mechanical circulatory support, to include extracorporeal membrane oxygenation therapy, left ventricular assist devices, and intra-aortic balloon pump therapy. I started my career at Cleveland Clinic in 2015 as a bedside nurse in the cardiothoracic ICU, where I'm actually now a clinical nurse specialist. And I provided care for patients with heart and lung transplant recipients, as well as patients requiring mechanical circulatory support. And then I transitioned to the cath lab in 2017 prior to entering my role as a clinical nurse specialist. I completed my master's degree from Kent State in 2021 and was credentialed and privileged as CNS at Cleveland Clinic in fall of 2021. And I eventually went on to earn my doctorate degree from Kent State University in May of 2023, and my doctoral studies were focused on improving nurse-led mobilization for patients receiving ECMO therapy. We're a high-volume, high-acuity facility, so this is a priority for me. And a couple other things to know about me. My professional passions include volunteering with the American Association of Critical Care Nurses. One of my recent projects include collaborating with them to help write an ECMO micro-credential for nurses who care for that specialty population. But I've also participated in other exam writing and review committees, to include the Cardiac Surgery Subspecialty Committee and then the Acute Care Adult Gerontology Clinical Nurse Specialist Exam Writing Committee as well. So some of my professional passions include being involved with these extracurriculars and then also encouraging other nurses to think about how they can have internal and external professional development opportunities as well. So that is a little bit about me. And the title of my article is ECMO and Nurse-Led Mobilization, Embrace Evidence-Based Tools to Empower Nurses.
Well, thank you so much for that wonderful introduction into who you are. And now we're going to pivot more to the article itself. So, obviously, you have so much that you've done in your life, but what makes you want to write an article like this? Like, what would be a reason that you wanted to write this article?
So I want nurses and anybody in the nursing profession to read my article to learn about post-intensive care unit syndrome, ICU acquired weakness, and evidence that supports early progressive mobilization for critically ill patients. Even those with cardiac assist devices. So the target audience for my article includes nurses, advanced practice nurses, or any clinician who cares for patients with mechanical circulatory support, specifically ECMO. But the basic principles of mobilization that I discuss can be used to impact other patient populations in critical care units as well. So the article is going to provide you with a thorough review of evidence to support mobilization for patients with mechanical circulatory support, but it's also going to describe some of the additional considerations for the clinicians to help make sure that the mobility experience is safe for the patient, especially if they do have mechanical circulatory support. It will help the nurse be able to perform basic assessment of the patient to rule in or rule out mobility readiness. And I would really like to emphasize that there are very few hard stops to mobility. Most of the time it involves a conversation about how we can mitigate risk and incorporate even low-level passive range of motion into the plan of care for the patient. So in my article, I think the biggest takeaway is that the nurse, the rehabilitation specialist, and provider team all need to be on the same page about mobility expectations and what the patient can tolerate, set a clear goal, and then decide as a team how the nurse can help bridge the gap between those scheduled rehabilitation sessions throughout the day. It's a team effort, and that is the biggest thing I want people to know.
That's awesome. So, you gave an example of why nurses should read it, and I was wondering if you had a specific moment or a specific anecdote for the inspiration for this article. Was there something that clicked inside of you that made you want to write this article? And if there was, what would that have been?
I think in my time providing care for this specialty population of patients, I realized that there is a culture of immobility. And in talking to many of my colleagues, including throughout the U.S., I realized that this is everywhere. This is something experienced by all healthcare providers. And it really centers around the concern that we don't want to harm patients by having them be mobilized and have a potential adverse event happen. But what we found in the literature is there's actually a very low risk of that happening as long as we carefully consider the patient and any devices that they have before we start to mobilize them. So in my own time, I've tried to figure out creative ways to incorporate mobility into the plan of care. And this article is designed to position the nurse to think critically about any barriers to mobility in their daily workflow and how they can start to navigate them.
Awesome. Is there anything else that you want to tell us about your article?
Yeah, I have 2 or 3 things I would like to discuss. So my hope is that after reading the article, the nurses and advanced practice nurses will have a heightened sense of awareness of post-intensive care unit syndrome, also known as PICS, and a better understanding of how we can combat this syndrome starting at the bedside with every point of contact. So the nurse is the first line caregiver. They're the one who is there with the patient 24/7. And we can incorporate mobility into their plan of care to combat ICU acquired weakness, delirium, and then generalized feelings of anxiety and depression for the patient. Mobility also affords family members an opportunity to be involved in the plan of care. So of course that's something that we would need to discuss with the nurse and the team, but it gives them a sense of empowerment and lets them be involved in the patient's care. And I hope that nurses can also read this and think of one specific tool that they can take back to their unit to help increase mobility in their own practice, but then also information they can disseminate to the rest of the team. So this is going to look different for everyone depending on the population they work with on a daily basis, and it will probably involve some constructive thinking and asking critical questions to narrow down the clinical problem. So does the team need to be better about formulating a daily mobility goal and have them displayed in the unit with a visual confirmation tool? Is there an opportunity to write a mobility protocol to delineate the bare minimum expectation for nurses and nurse-led mobilization to include a mobility frequency? And then would the visual goal targets be a helpful way to track progress in the units? Where's the best place to display that? Is there a dashboard that we could use? These are all things to brainstorm, and again, it will look different for everyone. And I think my last takeaway is just an easy tip that anybody anywhere can incorporate into their practice, including those outside of the ICU. So I like to recommend that an easy way to increase frequency of mobility is to start by incorporating passive and active range of motion, whatever is most appropriate, into the hourly or Q4-hour assessments depending on the unit protocol where you work. That's going to give you at least 3 mobility events throughout your scheduled shift, assuming you work 12 hours, in addition to anything that physical and occupational therapy have planned. And then always be thinking about how to increase the intensity of the mobilization that you're going to be giving the patient. If they can assist with turning in the bed, can they reach over and grab the arm rail? If you're going to be getting them out of bed to the chair, can they tolerate standing for an extra minute? These are things that you can be thinking of to always have the patient bump up to the next level of mobility that they're able to tolerate. And then you want to put that in the electronic health record to illustrate the progressive mobilization over the course of time. So it's just important to remind nurses that they can improve the patient's frequency and intensity of mobility. It doesn't just have to be our physical and occupational therapy colleagues who are doing this for the patient. So they should feel empowered to be able to independently evaluate the patient and discuss the readiness to mobilize with the critical care team or anywhere that the patient is. It doesn't have to be complicated, it just has to be safe for the patient.
Amazing. Well, thank you so much for writing this article and sitting down and talking about it with me today. We really appreciate it, and thank you again.
Thank you so much for the opportunity to be here.